This morning's event is brought to you by the Labor Council, Rochester, AFL-CIO, CBTU Rochester Chapter, and Metro Justice. My name is Shelley Clements, and I am the Executive Vice President.
He's in the library again, too.
I'm going to ask everyone to put themselves on mute. We'd love to hear you a little bit later. Okay. So my name is Shelley Clements, and I'm the Executive Vice President of the Rochester Chapter of CBTU and the Chairperson of the Labor Council's Education Committee. I would like to begin our program by honoring this space. We begin by acknowledging that through a history of colonization and brutality, we currently reside on lands that were stewarded by generations of Indigenous people. We honor these Indigenous people, all elders past, present, and emerging. We are called to learn and share these learnings about this tribal history, culture, and contributions that have been suppressed in the telling of the story of what we now call the United States. I invite you to take this time now to rename your window with your name, your required pronoun, and if you know it, the name of the native land from which you're zooming in on. I'd also like to take a moment to wish you a happy Women's History Month. Women's History Month is an annual celebration of the contributions that women have made throughout the history of the United States. National Women's History Month traces its roots all the way back to March 8, 1857. And that is when women from various New York City factories staged a protest over poor working conditions. So, been union strong for a long time. Our goal today is for you to get information. At the end of our time together, our committee wants you to be able to engage in conversations about this topic and to really know what you're talking about. We want you to understand the positions that unions around the state are taking and to be able to make informed decisions about whether or not to support this legislation in your contacts with your legislators. Our program today will begin with a summary of what the New York Health Act actually is and why it was introduced. One of the co-sponsors of the proposed legislation, New York State Senator Gustavo Rivera, is here to walk us through a description of the bill. From there, we will hear from representatives from our labor unions. Tracy Harrison, the Vice President of SEIU 1199, and Chris Rackle, the PAC Coordinator from CSEA, will share pros and cons of the bill from the labor standpoint and give us some things to think and to talk about. We've set aside time in the after the panelists' discussions for them to respond to the content that was shared. And then it'll be your turn to ask questions and get answers, okay? Education Committee member and Racial Justice Committee Chairperson, Sharifa Pryor, is the timekeeper for our session today. We want to make sure that everyone has an opportunity to be heard from. And Sharif is going to keep the trains on track. We'll do it nicely. We'll send a little email or a little message first, and then we'll be a little bit more bold with it if you go over your time. Okay, the chat room is open and it will be open during this session. So please feel free to use the chat room to share ideas and or ask questions of the panelists. So we will be monitoring the chat throughout the program. Okay, we do ask that you keep your mics on mute unless and until it's your turn to ask a question. And if you can, this is a conversation, it is a discussion, keep your videos on. Okay, I think that is it for housekeeping matters. So let's get started. The first speaker on our agenda is New York State Senator Gustavo Rivera. and he's going to give us a little bit of an overview of the bill that he is co-sponsoring.
Good morning, everyone. I'm very, very glad and very happy to be here this morning. It's not that sunny outside where I'm at. I thought maybe you were joking when you said that.
I very much so.
Okay, because I mean, where are you at? Because I know that I think one of my colleagues is in Colombia, so it might be sunny there, but it is certainly not sunny here. Coming to you from the Bronx, very thankful to be here. I will give a general overview, but let me say a couple of quick things up front. Number one, I am very thankful for this conversation, and I want you to know that on behalf of not only myself, but my colleague in the Assembly, Dick Gottfried, we are committed to making sure that this bill works for working men and women in this state. We want to make sure that this is something that works for every single New Yorker, but absolutely for every single hardworking union member across the state. And we remain committed to that, and we want to work along with you in this, right? That's why I'm participating this morning, and we will continue to be open to any and all ideas to make this bill better so that it can do what it needs to do, which is to guarantee healthcare to every single New Yorker and making sure that we can strengthen the labor movement, not weaken it in any way, shape, or form. What does this bill do? First of all, it starts with the concept that healthcare is a human right. That means if everybody could be muted, please, that would be great. Thank you. Healthcare is a human right. Now, that's something that while we might all believe, we have a system that currently does not do that, does not help us actually get there. Instead, and we'll talk about some of the middlemen as I go through this, we have, as opposed to you deciding what it is that you along with your medical practitioner, you have entities like, I don't know, health insurance companies deciding actually what it is that happens. So what would the bill do? The bill would provide for a single payer system that would have every medically necessary thing covered for every single New Yorker, regardless of their age, their wealth, their gender, their immigration status. It will have no copays, no deductibles, no out-of-pocket costs, no limited networks. And all of this, you might think, how is this something like this possible? Well, first of all, remember that systems like this are basically existing in every other modern American democracy. Modern democracy around the world. Whether you're talking about anywhere from South Korea to, Canada, much closer, right? Basically every single, it has been proven to work. How does it save money? Because that's the first thing we want to talk about. It is a system that saves money because number one, like any type of insurance-like product, although this will not be an insurance product, I want to make sure that we talk about that. But in any system like this, risk is shared, and it is shared among an entire population, right? So every type of risk pool, if you are part of a particular risk pool, that might be 20 people in a particular business, or it might be 1,000 people in a particular union, in a particular union local. But how about we create one risk pool that includes the entirety of the state of New York? The bigger the risk pool, the more things can be shared, right? So that's number one. Number two, administrative costs. Right now, private insurance companies waste between 15 and 18 cents out of every dollar on administrative costs. How about we go from 3 to 6 cents out of every dollar? We do that because we don't have to pay high CEO salaries. We don't have to pay all of the money that is paid to actually do ads and what have you. And certainly for the folks that you call, remember when you call an insurance company, most people are there not to actually guarantee you care. They are there to make sure that the company can keep most of that money. So let's get rid of administrative costs. Let's go way down. Third, providing everybody primary care. Now, since every single person in the state of New York, regardless of who they are, whether they're insured or not, is still a human, they will get sick. And ultimately, what happens when somebody has had a pain in the side of their stomach for 3 or 4 days? They'll end up in the emergency room, which is not only an incredibly expensive type of care, but also certainly is not going to, most people that go to an emergency room, it's not for their health, right? It is because they're in pain. They might be close to death, God forbid. But how about we guarantee primary care to everybody, which means that conditions like chronic conditions, asthma, diabetes could be identified earlier. This not only gives them better quality of life, but it costs less to the overall system. And finally, spending less on drugs. Because if we negotiate as a state, and you all folks know what it means to have a collective bargaining, right? So we collectively, if we as a group, as the entire state negotiate with drug companies so that they can actually give us better prices, they will actually give us better prices because we're negotiating for the entire state of New York, not for just chunks. So that is an overall how it would save money. Remember again that this is a plan that would include visual, it will include dental, it will include long-term care. Something that regardless of how good your particular plan is, long-term care is not included in it. And depending on what actually you've been able to negotiate for, you might have visual, you might have dental, but you might have to pay this, you might have to pay that, etc. So let's eliminate all of that. Now we'll finish with this. So I will make sure that we get into the debates of the pros and the cons, but just briefly to talk about labor here. The reality is that every single person here who's unionized could tell me, probably going back one contract, two contracts for the last decades, period, right? Plural, I mean, decades, plural, that every single time that you've been at the negotiating table, one of the toughest things has been, how do you keep access to your healthcare? And again, it's not access to healthcare, it's access to an insurance product that guarantees you a card in your pocket, but certainly doesn't guarantee you care. So if you have to give up things every time that you go to the negotiating table, because you always have to negotiate to keep a certain health insurance, how about we take that off of the table? We take that off of the table because we create a standard that is better for every single person, whether you're a member of a union or not. But now your union can negotiate for everything else. They can negotiate for retirement benefits. They can negotiate for better salaries on a year-to-year basis. They can negotiate for, I don't know, money for a college fund for your kids. And matter of fact, I'm sure there's many more things that you could creatively negotiate if you had more money to be able to not play with, but to negotiate for, because you wouldn't have to worry about securing insurance for your members. So you can still be an incredibly important, and as you always will be, an important part of making sure that workers are treated better, have better conditions, are safe in their home, are safe in their workplaces. But on top of that, you'd be able to get them more because you wouldn't have to worry about getting them one of the things that they should be guaranteed anyway, because it's a human right. So I will finish just by saying that I thank you for having this conversation. I reiterate that my colleague Dick Godfrey and I are committed to making sure that this works for every single person in the state of New York, but certainly for our brothers and sisters in labor. I'm actually a NYSEP member myself, taught at Pace University for a while. So I have been without being part of a union, I would not have been able to be here right now. So I thank you for this opportunity to be with you this morning. And now I will be quiet and I will be taking notes. Thank you so much for the opportunity.
I should really unmute if I want to talk, huh? Thank you. Thank you so much, Senator Rivera, for that overview. And now we'll move into a point of view from our Vice President of SEIU 1199, Mr. Tracy Harrison.
All right, thank you very much, Shelley. Senator Rivera, you must have read my notes. That was an excellent summary. I think you captured it all, quite frankly, but I'll take a stab at it. Good morning, everyone. Again, my name is Tracy Harrison. I'm the Area Vice President for 1199 SEIU, covering the Rochester and Corning District. Our members in 1199 SEIU, first we're a healthcare union, but our members work in hospitals, nursing home, clinics, and also work in people's homes. I'd like to thank you all for allowing me the opportunity to come before you and share my perspective on the importance of supporting the New York Health Act. Before I get started, I would like to give you some context based on my own 25 years of experience, both as a healthcare worker and as a leader of our union. I started my career working in the operating room as a unit support assistant, a USA, supporting the nurses and doctors in the everyday flow of the operation while they provided high levels of patient care as they were faced with some of the most serious healthcare challenges. Over the years, I became very interested in advocating for healthcare workers. I later took a job as an organizer for 1199 SEIU. Our top priorities have always been centered around advocating for quality healthcare for all. fighting poverty, and ensuring that our members had good, quality, affordable healthcare benefits. I carry a lot of those priorities into my role as an area vice president. That said, I believe that this has helped shape my viewpoint. 1199 SEIU, United Healthcare Workers East, firmly supports the New York Health Act, which we believe would provide comprehensive, universal healthcare coverage for every New Yorker. Healthcare for all is baked into our mission of our union. Why is this important? The members of our union see the consequences of a broken healthcare system every day, including patients arriving in the emergency room in advanced stages of disease because they did not have access to primary and preventative care. We have senior citizens skimping on needed medications because they cannot afford to pay for their prescriptions, and families are forced to make impossible choices about maintaining health coverage or paying for other necessities. This is a reality for many. Who would ever believe that our current healthcare system is far behind many other developed countries, although we have a stronger economic infrastructure than many, to include our gross domestic product, our GDP? I would have you consider this. The United States is one of the few countries in the developed world that does not guarantee access to basic healthcare for residents. Countries like Norway, Sweden, France, Japan, Denmark, Finland, and of course, Canada offer single-payer healthcare. This is not a revolutionary idea. They have had this type of healthcare structure for years. Every international comparison has found that countries with single-payer health system spend half to a third what the US spends, while providing better access to care and achieving better outcomes. In some cases, they have a lower GDP, but have still been able to provide this type of healthcare system. If we spend so much and have worse outcomes, who benefits from the current system? Think about that. Over the last 2 years, as insurers' profits have continued to soar, and our hospitals in New York are on the brink of collapse due to COVID-19, greedy insurance companies have continued to drive a wedge between doctors and patients. We've seen it, and we're seeing it over and over again. Since 2011, premiums for family coverage health insurance have risen by 47%, while other workers' wages have only decreased 31% over the same period. Premiums and deductibles now eat up more of the average family incomes, in the tune of around 11.6% as of 2020. United Health, the largest insurer in the US and one of the largest in New York, net earnings have surged since 2015, reaching 17.7 billion with a B last year, as their business has rapidly expanded into other healthcare sectors. In 2020, United Health Group CEO David Wichmann had a total compensation of over $17 billion. Another large insurer in New York, Anthem's CEO total compensation was also over 17 million in 2020. Christopher Booth, who retired as the CEO of Excellis Blue Cross Blue Shield in May of 2021, was paid $4.48 million. And James Reed, president and CEO of Excellis, was also paid at that same period of time $1.8 million. It appears that it's really all about the money, as opposed to quality, accessible healthcare for all. These are some of the many factors that go into why we cannot continue to stick with the current healthcare structure. I have personally witnessed workers who, because of poor access to healthcare, died prematurely. This is what we can continue to expect if we refuse to overhaul the current healthcare system. Without a right to healthcare, insurance coverage is highly discriminatory in the United States. Groups that are discriminated against in the labor market such as people of color and immigrants, are much less likely to receive quality workplace health insurance, while those with greater health needs, such as women, the disabled, and anyone with a chronic condition, suffer disproportionately from high deductibles and co-payments. This is very real. This is a reality for many of our folks. Even as a healthcare union, we have seen the extremes where workers have fought and won fully paid healthcare by the employer, in which the contribution rate are in the range of 43% of the gross payroll, which translates into millions of dollars each year. That same money could be moved into wages. This could have a significant impact on addressing poverty, which, by the way, is constantly on the rise. On the other end of the spectrum, we have nursing home workers who have limited access to quality health care. Many are responsible for paying thousands of dollars out-of-pocket expenses just to be limited to poor coverage. We've seen folks who've said, listen, I'm just not going to go to the doctor. I can't afford it. We've seen folks who, instead of calling the ambulance for a very serious health crisis, they forego it and try to drive in, which puts them in further danger. These are realities for our folks that we're seeing. These are actual consequences, unfortunately, for our folks not having access to good, affordable, quality health insurance. A single payer plan would eliminate administrative waste and allow for precious resources to be invested in the provision of healthcare for our state's residents. Senator Rivera touched on that very well. Bringing insurance administration costs down will save billions per year. By eliminating profits, you've seen the numbers, advertising, how many times you turn on the television and you're seeing these ads over and over and over again. They cost, lobbying cost, and exorbitant executive pay. A progressive financing mechanism with higher rates for higher incomes and inclusion of income currently not subject to the payroll tax would ensure that workers' wage increases do not any longer get diverted to pay for the ever-escalating cost of healthcare benefits. The inclusion of long-term support and services is a recognition of the significant hardship many New York families face in trying to ensure that their loved ones can remain in their communities with dignity and independence. The New York Health Act also recognizes the potential for displacement of workers currently working in the insurance industry and provides for resources for support, retraining, and placements in other jobs, which, by the way, for those who are against the New York Health Act, that's one of their issues that they'll argue. Where are the jobs, right? The system will fix itself and it will readjust. In implementing a universal healthcare program, it will be important to avoid unintended consequences and ensure that no working New Yorkers are worse off than they are under the previous healthcare system. Again, Senator Rivera touched on that and what this bill is going to include, which also, by the way, I would mention long-term care, very, very expensive. Again, many of our union members, for example, have been able to win comprehensive healthcare coverage paid for by their employers with no employee co-premiums, co-pays, or co-insurance. We believe this same type of comprehensive, cost-effective plan should serve as a model for any coverage developed under New York Health. We're not naive about the challenges to passing and implementing the New York Health Act. So while we are pushing for the bill's passage, our union is also pushing for budget actions and bills that will increase access to care for the most vulnerable New Yorkers. We're pushing for a significant additional funding for our safety net hospitals that are a key provider of care to the uninsured, undocumented, immigrants, and those who rely on Medicaid for their health care. We're supporting the coverage for all bill the A8808, and the SO1572-A, sponsored by Senator Rivera, that would provide adult immigrants with access to health insurance coverage that is equivalent to the coverage offered New York citizens eligible for the Essential Plan. And we're supporting Senate Bill 08470 that would tax insurance companies' profits and use that money to support distressed healthcare providers. As a country, we can no longer afford to sit back and watch as folks continue to be denied access to good healthcare benefits while insurance companies and other interests profits from a system that denies care. Let's put people over profit. We have to. It's time that we make quality healthcare right for all New Yorkers. The New York Health Act will finally make this happen. Make it a reality. Thank you.
Thank you. Thank you so much, Tracy. We appreciate that the information, the point of view, the points that you make on why we should be in support of or stand to support that legislation. Okay, and now we're going to I'm going to ask that you make sure that you're throwing your questions, your comments into the chat. It's a really interesting conversation that's going on over there too. And we will turn the floor or the video screen over to Chris Rockel from CSCA, who is going to share CSCA's point of view on the Health Act, New York Health Act.
Sure, thank you. I've got a PowerPoint that I'm going to bring up here. So hopefully it's popped up for you. Much of what you heard from the earlier speakers is true. Single payer healthcare would accomplish a lot of the things that they suggest it would, like lowering the cost of care and insuring everyone. Personally, I don't disagree with national single payer healthcare at all, but doing it on the state level is a different matter entirely. Enacting single payer healthcare on the state level blunts the benefits, and it introduces a whole host of problems that are too big for a single state to tackle by itself. That's why it's never been done before. Both California and Vermont started down this road before recognizing that it was unworkable and then retreating. It's indisputable that healthcare is broken in this country, in some states more than others. In New York, we're lucky to enjoy quality care that is likely the envy of many Americans. Our elected leaders have taken steps to improve eligibility and care, and as the most union-dense state in this nation, more of our citizens enjoy the top-notch insurance that comes with collectively bargained contracts. Healthcare in New York is certainly not perfect by any stretch, but what we need is precise legislation to improve the weak points of our system, not a radical, incomplete, and untried demolition. In short, we need a scalpel, not a shotgun. Perhaps the greatest virtue of single-payer healthcare is that it provides universal coverage. I want to take a second to clarify that people often conflate single-payer and universal healthcare as being interchangeable terms, but they're not. Single-payer is one, but not the only way to ensure universal healthcare, which means that everyone has insurance. Achieving universal healthcare has been and should be a priority for the state for quite some time. In the last decade, we have more than halved the number of uninsured New Yorkers, going from more than 11% to less than 5%. So who are the 5% left to cover? 300,000 of those are Medicaid eligible right now, but haven't signed up. An estimated 30 to 50,000 of these are invincibles, young people who just don't believe that they need insurance. And the remaining 600,000 are mostly non-citizens. That means 97% of New Yorkers are either insured or eligible to be. Perhaps a sweeping change like the New York Health Act would be warranted in a place like Texas, for example, where nearly 1 out of 5 Texans are uninsured. But we don't need to blow up the system to achieve universal healthcare in New York. It's already within our grasp as it is. In fact, there's already a bill in Albany to ensure non-citizens. Passing coverage for all would achieve near universal eligibility without needlessly destroying the system. Earlier, I called the New York Health Act incomplete, and that's because despite the bill being around since 2015, We still have no idea about basic things like how much it will cost. Advocates of the bill typically cite a study from the Rand Corporation that estimates year one costs at $139 billion. That's the best case scenario. The bill's sponsors have aimed a little higher with their best guess at $158 billion, while the Division of Budget states $200 billion. There are other studies that fall within a range of $200 to $300 billion. Call me crazy, but I'd like to think that we should be able to do better than come up with a $150 billion gap to answer a rudimentary question like how much it will cost to fundamentally overturn our entire healthcare system. Just to put this into perspective, because once you start talking about billions of dollars, it's hard to really get a handle on just how much money we're talking about. Our current New York State budget, which was passed last April, was $212 billion. It was the largest budget passed in New York history. The governor's Division of Budget proposed the cost of the Health Act at $200 billion, which means that the total New York State budget, including the Health Act, could double to more than $400 billion. So if the New York Health Act is going to double the state budget, where's all that money going to come from? A majority of funding for this program will come from a new payroll tax paid for by employers and employees. Employers like the state and local governments or private employers would pay 80% of this tax, and employees would pay the remaining 20%. I need to point out that because healthcare costs continue to rise dramatically each year, the numbers that we just discussed are just the costs for the first year. That baseline will rise each year, increasing the tax burden right along with it. That issue in particular, that year one was bad enough, but what does year 5 look like? Or how do we pay for year 10? Was one of the main things that killed California's attempt at single payer earlier this year. Proponents like to say that the plan will make healthcare cheaper. However, without knowing the cost, you can't really say that with any certainty. Sure, we know it will cost people that 20%, but 20% of what? You'd never buy a house without knowing how much your mortgage is. So why would we do it with our healthcare? Another really important point that we need to consider is whether there will be the same level of federal money for this plan. Right now, the federal government delivers Medicaid and Medicare dollars to New York State, which accounts for about 34% of New York's healthcare funding. New York would need a federal waiver to redirect these funds for the program, which is not guaranteed. However, and I can't stress this enough, the proposed legislation of the New York Health Act directs the state DOH to implement the act regardless of federal waiver approvals, meaning it's possible that New York State would have to dramatically raise taxes even higher if we have to make up for the lack of funding from the federal government. In 2011, Vermont became the only state to pass a law establishing state-level single-payer healthcare in the United States. Vermont quickly realized the cost of a state-run plan would be higher than anticipated and would nearly double the state's budget. To pay for this, Vermont planned to increase payroll taxes and income taxes. Sound familiar? In the end, Governor Shumlin abandoned the plan, citing, among other things, the massive cost of this plan was just simply unworkable. If a small state like Vermont, with a population of less than 1 million, couldn't figure it out, how can we expect it to work in a state with 20 times the population? Simply put, single-payer systems are meant to be national systems, not state ones. And trying to implement a set of rules that one state plays by while the other 49 don't creates inefficiency and a whole host of other problems. Proponents say the New York Health Act will lower the cost of care, yet a state system is wholly inequipped to do so in a positive and meaningful way. For example, one of the leading drivers of healthcare costs are prescription drugs and medical devices. Almost, if not every successful national single-payer system negotiates the price of these items. It's why, for example, a vial of insulin costs $7.52 in the UK, but $98.70 in the US. The New York Health Act does not have the teeth to be able to fix this issue. In an attempt to drive down costs, the legislation would allow the DOH and a board of trustees to set reimbursement rates and fee schedules that would apply to all providers. Yet again, the idea falls victim to the perils of a state-level system. While this certainly would do some to control costs, it restricts how profitable a physician can be. Simply put, if your doctor can make more money in Pennsylvania, New Jersey, Connecticut, or any other state, they'll close shop here and open up elsewhere. According to the CDC, New York ranked 4th in patient care physicians per capita, which is 28% higher than the national average. That is something to be celebrated. But passing the New York Health Act would destroy one of the best aspects of our healthcare system, and in turn create a problem that doesn't exist. And that's not the only complication that arises from enacting single payer on the state level. Among other concerns that the New York Health Act has not figured out is how New Yorkers would receive care in other parts of the country. For example, your family's on vacation out of state. Would you be covered? You are a retiree living in Florida who receives healthcare as a part of their contractual benefit that you received while working. What happens to that coverage? What about if you live out of state? Your doctors are out of state, but you commute and work in New York. Would you be covered? That we can be 7 years into this legislation and still not have concrete answers within the bill makes me feel like either they don't have the answer or that there is one and that people just simply won't like it. I stated earlier that we don't need single payer healthcare to achieve universal coverage. We've made great strides over the last 10 years to have one of the lowest uninsured rates in the country. And as you can see, New York State is not content to rest on its laurels. Instead, both the governor and her executive budget, as well as the legislature with their Coverage for All bill, have continued to take steps towards expanding care, making insurance more affordable, and achieving universal coverage. I get it. I do. The American healthcare system is embarrassing on a global scale. We spend more on healthcare than any country in the world and arguably get the least back in return. We read stories about how the skyrocketing costs of EpiPens, for example, is forcing Americans to cross the border to get them because they're as much as 10 times cheaper in other countries. Europeans are horrified by the stories they read about American healthcare and just can't seem to wrap their heads around the fact that this is the richest nation on earth, but we don't view healthcare as a human right. So I understand the fight for New York State single payer, especially given today's political realities. The brokenness of Washington can make advocates feel helpless that politicians will ever do anything themselves. And hey, New York's always been a progressive leader. Why shouldn't we step up where DC can't or won't? The answer is that to do so would be short-sighted and damaging to the long-term goal of a national system. Look at the lies and vitriol that were spread during the fight for the Affordable Care Act. We're only going to get one chance at single payer, and a mass exodus of doctors, long wait times for care, or an exponential explosion in taxes to keep pace with the ever-increasing costs of care will forever poison the movement. President Obama tried to give people health care, and all we heard about for months were ridiculous things like death panels. However, we must ask ourselves, what will it look like if they actually have facts on their side this time? It's possible to support an idea, yet oppose its execution, and that's what we have here. National single payer is a revolutionary cure to what ails American healthcare. But the New York Health Act is an expensive and unworkable solution that has the potential to doom national progress forever. Thank you.
Thank you so much. Thank you so much for that point of view, Chris. And thank you for the information that you put into the room for us to talk about in the chat and together as a labor union family. Can we have some time now for responses to the content that you heard? And we'll do it in the same order that you made your statements. So we'll start with, we're calling it a rebuttal, but it's not really a rebuttal. It's more like a response to what it is that you've heard. Senator Rivera, if you could start, and then Tracy will have an opportunity to have a response to the content that was presented. And then Chris, you have an opportunity to respond to what you're hearing. Okay, Senator Rivera.
Thank you. And thank you so much for this opportunity to have this conversation. Again, I will just cover some quick things, and then we'll obviously go deeper into them. It is true that a national system would be the way to go, but the fact that I believe that states can lead and should lead. I believe that the state of New York can. And two issues on that. Number one, the system in Canada started in one of the provinces, Saskatchewan. So it actually can start in one part of the territory, even if it's a federal system. That's number one. Number two, Vermont, you're correct. Vermont did not successfully achieve it because Vermont is a very different state as far as population, tax base, and they had not thought through the whole financing plan in ways that we have. So there's that. Number two, one of the things that continuously is ignored in the presentation, because a lot of the stuff that you said is absolutely on point, but you ignore one big thing, and that is underinsured. Having insurance, everybody in this room, I'm sure yourself, sir, can also attest to the fact that just because you have insurance doesn't mean you're going to get care. Because if you have a company whose job it is not to provide you care, because that's not what insurance companies do. Insurance companies are in the business of keeping the money. So people are underinsured. They might have high deductibles, they might have limited networks, which, by the way, the response will probably be, well, we have great benefits because of what we negotiated. God bless America. That's an excellent thing. However, all of you have limited networks, every single one of you, regardless of how good your plan is, you all have limited networks. And none of the plans include long-term care. Also, as far as the waiver issue, it is true that having a waiver, because basically getting a federal permission to spend Medicare and Medicaid money on this is absolutely, it would be necessary, but we can still do it without a waiver, because ultimately what we have to do is just be able to evidence to the federal government that every single dollar that is coming from them is going to services that are permitted under federal law. So getting a waiver means that it would be much easier. They would be cut a little bit into the savings if we don't have a waiver, but as long as we can tell and we can evidence to the federal government, this dollar that is federal, that they're sending us, is only being utilized for federally approved things, we'll be fine. And that can be done through software. So it's not that difficult to do. So a waiver would mean that we wouldn't have to do that. We would just be spending the money, and it would be, federal share, state share, as much as we do for everything else. But those are just some of the responses there. I'll leave it to Tracy.
Thank you, Tracy.
Yep. I'll start also with Chris's comment that this is too big of an issue for one state to handle. I disagree. I think that if there was going to be any state that was going to try to pull this off, it should be, and it would be, New York State. To his point again, he said that New York is one of the highest states of union density, right? We have a lot of power, we have a lot of strength, a lot of resources in that in itself. And I think that that can help push it. I think that there's more support behind the New York Health Act than folks really realize. This is a very, very important issue. Secondly, he mentioned cost. Cost is always going to be the issue, always going to be the issue on the table. I hear that, on a daily basis from the boss, right? They don't want to pay for a good quality, affordable health insurance for their workers. We have to, at some point, get away from that. The same issues, the same barriers when Medicaid, Medicare came into play. If we had just stuck and said, hey, it's a cost issue, where would we be at today? We got to start somewhere, and I think it's now. Chris also mentioned that, he agrees that our healthcare system in some aspects is embarrassing, especially when you do it, you're comparing it to other countries. We shouldn't have to be, it shouldn't have to be, right? I think that we can do better. There's a lot of monies that is coming through this country, and this should not be an issue. We should not be in 2022 still talking about how do we ensure that our folks are having full access to good quality healthcare benefits. I agree with Senator Rivera's point too, is that, you can have health insurance, but it doesn't mean that you're going to have good quality health insurance. There's definitely a difference. And we've seen that over the year. I've seen that over the years. And unfortunately, it has translated into individuals with poor health outcomes. So I think those are some of the factors that we definitely should take in consideration. Thank you.
Thank you, Tracy. Chris?
Sure. So I'll start with the idea that the Canadian system started in one province and became national from there. That was in Saskatchewan in 1948, I want to say. Saskatchewan is a province that has a population of 1.1 million people in a state the size of Texas. To say that what they could do 70 years ago in a state that looks absolutely nothing like New York, I think there's not a great correlation there. Underinsured are certainly an issue. And earlier in my presentation, I said that we should be taking a scalpel to the system that we have. We should be taking a look at the weak points and using precise language and precise legislation to address those issues. I think the governor in her executive budget looks at increasing the eligibility for the state essential plan, which is for people that make too much for Medicaid, that sort of fall into that donut hole. They make too much for Medicaid, but still can't afford their insurance. I think that's a great example of ways that we can improve the system without absolutely blowing everything up. The cost is, as Tracy was saying, he mentioned it's always going to be a problem, but that can't keep us from doing something like this. States can't run a deficit, and the federal government can. And so if this program becomes more expensive than expected, or continues to grow each year, year after year after year, there is no way to address that outside of increasing the tax behind it. He mentioned Medicaid and Medicare being expensive. Yes, those are federal programs. The federal government can run a deficit. So they can make sure that we have those programs and they just figure out the money behind it. The state can't run a deficit. We have to tax our way to pay for it if we're going to. And I think lastly, nobody addressed the fact that doctors will leave this state if we impact how much they can make. One of the arguments that you hear from people on a national level is, well, if we do national single payer, doctors are going to leave. And I don't believe that that's the case. I don't think people are, like we talked about, most countries in the world have national single payer healthcare. So I don't know where they're going. But if one state has this and the others don't, they could certainly leave. I mean, I think I was somebody who grew up on Medicaid, and it was very difficult to find a doctor that would take Medicaid because they could make so much more money elsewhere. And so it's very expensive to become a doctor. The loans are very expensive. If you reduce the profitability, I think you could see a position where healthcare professionals leave this state, especially in a year where I think the governor is proposing, I think it's $2 billion to recruit and retain healthcare professionals in this state. It's counterintuitive to enact a proposal that would watch those people then leave.
Yeah.
Okay. Well, if I let you, I have to let everyone else. Okay. So we can have another round of responses, and I'll ask folks to start putting their questions in the chat so that we can have questions after this next round. Okay.
Less than a minute.
Okay, everyone. Okay. Senator Rivera gets less than a minute. VP Harrison gets less than a minute. PAC person, Racco gets less than a minute. So there you go. Go for it.
The bill actually has language. It is true that Medicaid pays down here, Medicare pays over here, private payers over here. How about the bill, which has language in it, which would make it statutory that the rates to be created need to correspond to what the cost of care actually is. Therefore, everyone will get paid over here. Now, they won't get paid over here with private payers here. They won't get paid where Medicaid is down here. Everyone will get paid better. And also, how much money and time do doctors spend actually fighting insurance companies? You get that out of their costs. They will actually take care of people, make more money, less than a minute. God bless America.
Thank you. Thank you. Vice President Harrison.
The only thing I would say is this, and I'm going to defer to what is a real reality for the thousands of members that we represent. When we look at a nursing home worker who have been working at an institution or facility for 30 years, and they don't have good access to good, affordable healthcare benefits. And unfortunately, when something hits them, cancer, they end up dying prematurely. We see this, I've seen this time and time over and over again. So we can get wrapped up into the economics and whatnot, but it still comes down to everyone. This should be a human right. Everyone should have access to good, affordable healthcare benefits. And that's, I mean, I don't think that it gets any simpler than that.
Okay, thank you. Chris?
Sure. I mean, I guess the only thing that I'll say is I agree with national single payer healthcare. I do agree that our healthcare system is terrible. There's a comment in the chat about when did unions start supporting corporate greed. I'm not arguing that health insurance company executives should be bringing home $20 million bonuses. I just think that doing it in one state isn't going to A, fix anything related to that, and B, I don't believe that it's workable. I think that if it were workable, any of the states that have shown interest in doing so would have gotten somewhere on this issue. I think there's a lot of interest on the state level to do this. And I think once they get to the nitty gritty of actually trying to put it into place, they find out that it doesn't work.
Okay. Thank you. Thank you. Just a couple of quick questions for all panelists. And actually, I think Senator Rivera will probably be better able to answer this one. Exactly where is this bill in the legislature right now?
It is currently in my committee. It is in the Health Committee in the Assembly and the Health Committee in the Senate. I believe, and my staff is on the call, so they should. I believe it has 33 sponsors at this point in the Senate, and we're having internal discussions in the conference, in the Democratic conference in the Senate. There's a working group that has actually gotten together, and we're kind of trying to hash out some of this stuff internally, that's where we are for the moment in the Senate.
Okay, and then just again for clarification, I think both Chris and Tracy used these terms: universal coverage, universal health care, and single payer system. Can you please make sure we're clear on what is the difference between the two, or are those terms interchangeable?
Yes, correct. They're different. But I'm sorry. I don't know if you wanted.
Well, I just need an answer. So whichever panelist would like to make clear the distinction.
And Chris could certainly correct me if I'm wrong, but single payer just means that we, instead of having a multi-payer system, like right now, it is either a private company, your pocket, Medicaid, the VA, et cetera. That's a multi-payer system. Single payer means that every single bill is paid by one place. And universal coverage could be generally described as everybody having access to something, whether it's an insurance product, which is the argument that's being made right now. 95% of people in the state of New York have some level of insurance. 5% of people do not. And so gaining universal coverage would be having 100% of the people have some sort of coverage, period. But as we stated clearly earlier, being insured doesn't mean having access to care. But universal coverage does refer to having everybody having something, and single payer means, because we can have a multi-payer system while having universal coverage. That can happen. I don't know if Chris, am I right?
No, that's totally right. Yep.
Okay, and then, actually Jeff just put a version of the question in the chat. Do we expect, is single payer or universal health on the national agenda at this point in time?
Sadly, no. We're too worried about what is it, like all the craziness that the Republicans are worried about. So I don't think it's on the agenda right now.
Okay. Okay. Then the next part of our time together would be a question and answer period. So if there is a question that you all have, then now's the time to ask it. And I saw Jim Bertolone's hand go up. I saw Dan's go up immediately. So can we? I'll give the president of the Labor Council the first go around, and then Jim, as president emeritus, can go next.
Hey, thank you for that, Shelley.
Okay.
I'd like to thank all the panelists. Senator, full disclosure, I'm out of United Auto Workers, and we fully back your bill, always have. We're all on board. We want to reduce this cost, take it out of from the bargaining table, like you said, and go after those wages, retirement benefits, and vacation, other things for folks. We've seen this work, like we said, all across the nation. You've seen in the chat, Our GDP is the same size as nations in New York State. So we should be able to do this, show the nation that it works, reduce the cost. As far as getting those healthcare workers in, I believe we can, right? And again, fix the immigration problem. There's healthcare workers across the globe that would gladly, right, flow into the New York healthcare system and man it up if people ran away for greed. But again, Chris, I'd like to thank you. I think it's brave. You were up here. We got to hear these opposing viewpoints. It looks to me like in the chat, 90-something% of the folks on today disagree with CSEA. So thank you for coming on and telling us that viewpoint. We have to hear it so we can hear all the angles, so we can build this better system, so we know how to fix any legislative problems and work with the senator to make it right. But Lord knows it's a moral imperative. It's an economic imperative that we get this done. And like I said in the chat, I agree with Chris. If we do it wrong and we fail, right, the right wing nut jobs are going to be attacking us for decades. See how they failed in New York. So we need to do this once again, all in, and do it right. Thank you to all the panelists. Tracy, we know you live this kind of work every day. So thanks, guys.
You're welcome.
Thank you. Jim, before you ask your question, I got a note that asked me to, I asked about universal health or single payer being on the federal agenda. I was asked, is it on the New York State agenda? So I think Senator Rivera is probably the best person to answer that one. Is universal health or single payer system on the New York agenda?
Well, we're certainly working on universal coverage right now. There's a bill called Coverage for All. This was mentioned actually by Chris earlier, and we're certainly trying to make some progress on that. It would actually extend the essential plan to undocumented folks who currently have no coverage of any kind, and that's certainly a step in the right direction. But I continue to fight to say that that's an important step. But certainly, what we need to do ultimately is pass the New York Health Act. So it is and I have a couple of colleagues who are actually in the chat. In the room right now, Senator Jabari Brisport, Senator Rachel May, Senator Jessica Ramos, and Senator John Liu. I don't know if other folks made it as well, but and some of them there, Jabari, and they're also with me, kind of trying to put it on the agenda. But a lot of stuff that's being discussed, and we're just trying to see how much we can actually get done.
Okay, thank you, Jim.
Yeah, I'd also like to thank Shelley and all the panelists for all the information. I want to start with going to what Tracy said about some of the salaries. What's interesting to me is some of the people making $1 million salaries, and there's a lot of middle management under them making high six-figure salaries, are nonprofits. And they put these $1 million salaries under their labor costs. Now, unions are nonprofits, and if any of us paid ourselves $1 million, we would immediately be arrested. So I do think that Senator Rivera, some of this has to come with some key regulation. We are paying these big salaries to people who do not cure anyone and are not scientists who invent the cures. That's where our healthcare costs are coming. So I really appreciate Tracy bringing that up. For my fellow brothers and sisters here, one of the books I just purchased on my reading list is The Privatization of Everything. And those of you in the public sector know we've been fighting this for decades. This is our big problem here with the privatization of healthcare. And I'd also want to remind my union brothers and sisters that this passed almost unanimously single payer Medicare for all at the AFL-CIO convention in 2008. And in discussions with then Democratic primary presidential designee Obama. So this is not new. We have already bought this. I think last thing I want to say is just a comparison. Italy, which it's Medicare for all, like England's was underfunded. They've refunded after what happened with COVID. Italy has less than one half the per capita income of the United States. 30 years ago, we had the same life expectancy as Italy. They now live almost 4 years longer than us. This is costing not only still the #1 cause of bankruptcy, it is anywhere between 20 and 40,000 deaths a year because we have privatized healthcare and people don't have it. Even with people who with Obamacare and like us with decent healthcare coverage, copays and deductibles can be so expensive that people do not go to a hospital or for care unless they're in an emergent condition. So I want to thank Senator Rivera for his work on this. I think it's real important. As far as the 95% covered now in New York, I want to thank Joe Paparone for answering my question on the chat line. The public health emergency for COVID ends in April. That froze everybody on the Medicaid rolls. There'll be 60 days where they start taking the ineligible off. And New York is expected to add 1 million uninsured who will no longer be eligible for Medicaid in about July. So that 95% figure is going to change this summer. Thank you.
Thank you, Jim. Thank you for those ideas and putting that information into the room, putting that question into the room. Joel Schwartz, your hand is up.
Yep. Hi, how are you? Good morning.
Good morning.
And I just want to say hello to all my CSEA sisters and brothers who I haven't seen in years. Joe, Tim, Bess, and whoever else is on the line. It's nice to see you guys. So I'm somebody who was on the CSEA statewide negotiating team 6 different times between 1985 and 2007. And I was on our health insurance subcommittee 5 of those times. So I know a lot about health insurance. And while I'm in complete support of the New York Health Act and have been for many years. The first conversation I ever had with a politician about this was 1985 with Mario Cuomo. And that's true. I have a picture to prove it. The thing about that I agree with Chris about, and a weakness in the bill that I see that I really think would be helpful to fix is the costs. You know, we don't know what it's going to cost. Because the financing is not in there. Now, the Rand Corporation study showed 4 different ways of paying for the New York Health Act. And each one of them showed substantial savings in the billions over 10 years, if we implement the New York Health Act. But the bill itself does not have it. And to ask unions that have relatively stable, decent, not great, but decent healthcare, including my healthcare, to ask unions to give that up for something that's not determined is difficult. It's a difficult leap for any union to make. And folks who are sponsoring the bill have to understand that. And Gustavo, we've had these conversations, and I know you know that. So the one other thing I do want to say, though, is that in terms of costs, for CSEA members, the average member who pays a family premium pays between 9 and 10% of their salary for premiums. That's a premium before you see one single doctor. Before you see one single doctor, 10% of your salary is out the door. And because we know how universal systems work around the world, we know how these things are financed. We know that we're not going to pay anywhere near 10% in a universal single payer system in New York State. We don't know exactly what it's going to be. And I think it would be really helpful if we could get to more specific numbers about what it would actually cost so that we can show union folks that, hey, this is really going to save you money. And I'll stop there. Thanks very much.
Thank you, Joel.
You're welcome.
I guess in my regular, in the role that really pays me, I'm a labor relations specialist for NYSET, and I negotiate contracts and enforce contracts for a living. And I think it's really important if someone can make it clear, right now, if my local, if a member in my local is responsible for 10% of the premium, they know that this is how much they're going to pay. I guess I'm really not clear with the Health Act how do you know what your contribution to your health insurance is going to be?
And I would tell you, first of all, right, it is true that there's a level of uncertainty, right? That I can't tell you exactly, right? There's certain analysis that we can do, and we can do deep dives, and we can certainly do deep dives into the models that, for example, the Rand Corporation did, and we can do that. To say that that's going to be exact to the letter and to the cent, I can't do that for you, right? I would argue, however, that that the same is true even for the benefits that you negotiate. You don't even know what you're going to be the next time that you sit at that table. You don't know what the overall conditions are going to be in that industry. You don't know what the overall conditions of the economy are going to be. You don't know who is going to be leading that particular agency or entity that so you don't know if they're going to play hardball. You don't know, since the way that you actually, like who are the doctors that are providing the care, that is a network that you're attached to. There's a lot of uncertainty already in the system. And I'll talk about cost for a second. The issue here, the reason why these savings are possible, and Mr. Schwartz and probably everybody, like a lot of other folks will be able to tell you this, is because what we're doing is, and we need to be very, very clear about this, we are taking, and this was said in the chat, we're taking the profit motive out of it. Now, and by the way, because Chris did talk about the profitability that certain doctors do, the reality is I certainly don't want doctors to leave. And let's talk about this. Hospitals, for example, safety net hospitals that serve poor and working class people all over the state, whether it's urban like St. Barnabas Hospital right in my district, or rural hospitals in different places in the state that serve an overwhelming Medicaid population, they will see their revenues stabilize in ways that we can't do that now. Because if we have most of your Medicaid patients, most are poor working class folks who are high needs, they're going to be Medicaid patients. Medicaid rates are down here. They can't really survive on that. So the level of uncertainty is there. I cannot tell you, like, to the cent. I can't do it. And I understand, and Mr. Shore's brother, I absolutely understand. I call it the bird in the hand issue, right? I know and I respect immensely that you folks have fought to get what you have in your hand, what you have right now, which in many instances is better than most working people in the state. This is why unions are so damn important, because you folks actually go in there, battle the battles that you have to have, right? And then make sure that you get the best possible benefits for your members. And I'm telling you that what we're trying to create for everybody is not only better than what you have there, but whatever you could get, we're going to offer you something better, which certainly is hard to believe. But I would again say that if there's evidence in other places that it's happened, and it's happened all over the place, there we have a state that is wealthier than other states, more populated than other states. And if we get everybody under one system so that every single person, including myself, including whomever the governor is, including as many wealthy folks as you can imagine, and every poor person, and we get them in the same system, we will obviously make sure that it's a system that serves us and our families well, so you and your families well as well. So for all of those things, it's as far as...
Okay, thank you. I have can any of the speakers speak to why universal single-payer healthcare is a racial equity issue? Can any of the speakers speak to why universal single-payer healthcare is a racial equity issue?
I could take that one, Shelley.
Thank you. Thank you, Tracy.
Not a problem. When we look at, and I'll just use our union as an example, when we look at a lot of the folks who are working in these nursing homes, hospitals, doing home care and stuff like that, it's a large African-American population. It really comes down to affordability, poverty wages, health system mistrust. I mean, there's a whole, ton of different factors that goes into that. And that's what we're seeing and have seen out there. So, again, it comes down to affordability.
Okay. And that's a valid point. It comes down to affordability. So that leads to a question about taxes. How much of an increase in taxes, and whose who would be taxed for this? Is this a case where, like in education, we keep saying tax the rich and then we'll get this, make sure millionaires pay then we'll get this. What is it going to do for the taxes of people if you have access to health insurance, but now your taxes are at 40%?
It is true. It is true that there is a new tax that's going to have to be created to actually fund this. That's true. But unlike many of my colleagues, I am not scared to say that, because the nuance is the following. The tax that will be created will be a payroll tax based on an ability to pay. Furthermore, the way that the bill is already written, it says that 80% minimum of that payroll tax is covered by the employer. And I can hear the response. Wait a minute, we don't pay anything because we've negotiated that. First of all, the bill allows for that because, as it says, 80% minimum for the employer, 20% maximum for the employee, which means that in negotiations, y'all can get the employer to cover 100% of the payroll tax. Furthermore, think about the fact that even though you say you're not paying anything right now, when you think about whether there's limited networks, and regardless, as I said earlier, regardless of the coverage that you have, you will always have a limited network right now, always. The formularies are determined not by you, and depending on the plan that you have, do you have copays? Do you have deductibles? Now, some of you folks don't, and again, that is an excellent thing. And I certainly don't want to take that away from you. But what I want to make sure is that you remember that the reason why in certain plans that you have right now, I would argue you're under the impression that you don't pay these things, but you negotiated to keep that, which means that you probably had to give up raises, had to give up other benefits. Again, take this off the table. Take this off the table. If you have no copays, no deductibles, no out-of-pocket costs, no network costs, no out-of-network costs, all those things save money. So yes, there is a creation of a new tax, a payroll tax, that is a graduated assessment based on ability to pay. It will be more for folks that can afford it, less for people that can't afford it, and I think it's 30,000. Oof, staff, help me out here, because there's basically under a certain amount, the tax doesn't exist at all. Ultimately, throwing everybody in the same pot, everybody in the same mix.
So
sorry, I kind of go
if
on.
you throw everyone into the same pot, I guess again, my LRS hat is on. What happens in this scenario with people who are already retired and have benefits that are benefits and a certain level of benefits that's already been promised to them until they move on to a better place?
Very glad you asked this. If these folks are retired in the state of New York, their benefits are going to be better than what they've gotten, because whatever retirement plan, I know you put the face like that. Does the retirement plan include long-term care? Does the retirement plan include not paying for drugs? Does the retirement plan include vision? Does the retirement plan include dental? If the answer to any of those questions is no, the New York Health Act, which would cover every single New Yorker, whether they're retired or not, is immediately better. And if someone is a retiree in another state, the answer to the question is, however it's done exactly right now, it's exactly the same way that it will happen. Right now, if you're a retiree and you live in Florida, what happens, right? Your benefit fund here negotiates to give you access to some level of care in Florida. It will work exactly the same way. That doesn't get taken away from you, because those are benefits that you've negotiated and are locked in. The fund can still pay for those things, and it will work exactly the same. But again, if you are a retiree in the state of New York, the benefits will be above the benefits that you have right now in whatever retirement plan you got. Or you still have the face? You still like this?
Yeah, I do. I do.
All right.
Jim, go ahead, and then we'll get back to my face.
Here, let me unmute. I just wanted to say, and you probably all have different experiences in collective bargaining. I was involved in 3 national negotiations for the largest single unionized employer in the country, and that's the Postal Service. And the way our negotiations work, the employee is paying the total cost of the health benefits, not the employer. Same thing for Social Security. The employer goes in with a bottom line, and the union tries to get as close to that bottom line. And just for example, say the employer's bottom line is $40 an hour. They don't care if the union, for the most part, and there are exceptions, they're going to take $25 an hour wages, and the other 15, they don't care if the union and its employees want $5 an hour to go to health care, an average of 10 grand a year, half a buck an hour to go to life insurance. The employer's end of the Social Security costs are in that $40 an hour. You may think your employer is paying 80% of your wage benefit. That is out of the wages they agreed to pay you. When their bottom line is $40 an hour, that's all benefits, and that is the cost of the labor. You are in reality, your workers paying the entire cost of healthcare, the entire cost of Social Security. That's how business works. This is my bottom line so that I know what my labor costs are. And how the union wants to divide that up to benefits and wages, they, for the most part, don't care as long as they do not exceed their bottom line. Just my experience in contract negotiations.
See, and my experience is just a little bit different. The pie that we have, for lack of a better term, particularly in school districts, is the tax base of that community.
Right.
So I'm still trying to figure out, and what this phase is saying is, okay, still, how is this going to work? When I'm dealing with a district who's only got the taxes that they've raised, the taxes that they were able to raise from their community, and how much bargaining, or what role in terms of bargaining would this health act, or as you're describing it, what would it mean to wages in my community? And I don't see it freeing up any money. I just see it rearranging the money that's available from the taxes that community members are willing to pay. I don't see it freeing up money for my members. And again, my situation may be different because I am dealing with what taxes will be allowed in a community, and that doesn't even speak to the big five school districts who don't get money from community taxes.
Excellent point. We're the only public union under the National Labor Relations Act and aren't dealing with taxes, and you're also negotiating with people that, to a man and a woman, almost all ran for office on the promise of cutting taxes. Mm-hmm. I ran for office, so I don't envy your situation.
And that's the reason for the face, Senator Rivera. But before you answer that, I'm going to ask you to put that on hold because Sergia Coffee, I hope I'm saying your name correctly. Please correct me if I'm wrong. Will you please ask your question? Because I feel like I'm talking too much, so I gotta let somebody else ask the question. I'm sorry, we can't hear you.
Oh, you can't? Okay.
Thank you. That's better.
Hold on. So now I'm delaying you. I'm sorry. I just wanted to.
Okay. She's broken out. So I guess Senator Rivera, can you go ahead and answer my question while Sergia gets her sound back, and then we've got a couple of other hands.
And I'm sure that Len would probably be able to help Ron. Oh, there's Sergia.
I'm sorry. I apologize. I didn't get my plugged in. Okay, so for example, in 2016, under the New York Health Act, the Saratoga school districts would have saved $18 million. $18 million. That's information based on the RAND study done by Dr. George Jolly, a retired medical doctor. $18 million. You can look at that for every single school district. You can look at that for the towns and for the counties. I can send you information if you need it. $18 million. When you're fighting for lower taxes or money for your school district and you're saving $18 million, that's money that can go to more teachers. It can go to better pay. It can go to more services for the schools. We are throwing money away whenever we are spending 15% of every medical dollar. Plus, we've got all sorts of dysfunctions. The healthcare is not a market. You look at healthcare as a market. You cannot be having a heart attack and comparing which ambulance to get. You can't go out there and get the information on which hospital's charging what. And even when you're in the hospital, nobody knows what your insurance company is paying compared to someone else. It's a dysfunctional system. It does not work like a market, but we would save literally millions of dollars for school districts. That's the point I'm trying to make. Millions of dollars that would go to whatever people want to negotiate. That's my point.
Okay, thank you. Thank you for putting that information into the room, Georgia. Len?
Yeah, I'm Len Rodberg. I've worked a lot on the economics of this bill. I'm helping the sponsors develop some plans that will show what it will cost. I mean, I am one who believes that the cost should be in the bill so it would be transparent, but I can tell you that given the provision in the bill that the first $25,000 is not taxed, and given the costs that we get, pretty solid estimates of what the overall cost will be, I can tell you that no one whose income is below, say, $100,000 will pay more under this bill. Everyone, or put the other way, anyone whose pay is below $100,000 will save money under this bill. We'll have less costs in a combination of what's taken out of their paycheck and what they spend on healthcare than they're now spending. Again, I think it'll be helpful to actually have tax rates in the bills because it'll be more transparent. But no matter what the rates are, given that it's required that you first $25,000 exempted and it's required to be progressive, no one whose pay is more than 100. I'm sorry. No one whose pay is less than $100,000 will be spending more under this bill than they're now spending on healthcare.
Okay, I got a text message question. It says, will I have to add money to what the state pays? So, like sometimes if you choose a different dentist, you'll have to, your insurance will cover some and then you have to add money to it. So they want to know, will I have to add money to what the state pays?
No, ma'am, you will not.
No out-of-pocket costs under this bill.
Okay, thank you. Okay, I think that the point that Chris was seeing no other hands raised. I think that the point that Chris made was a very valid point about do we have to blow up a system? Can you make surgical cuts to correct problems? And that was not something that I heard addressed by the senator or by Vice President Harrison. So if you blow up a system, if you blow up a system, then it takes time to rebuild it. So what happens in the meantime is a trial and error period, right? And how long does it take to put a new system into place? And what happens to those folks who fall through the cracks when you do that? So the question then is, why is it not a discussion about surgically addressing the problems in the system?
First of all, even if the bill passes today, it would still take a few years to actually flip the switch. It's not something that would happen automatically. So as far as the blowing up analogy is not totally correct, because we wouldn't be saying like, well, today is a Saturday. By the time that Monday rolls around, everything will be different. Like it's not going to be like that. The bill would pass, a financing plan would pass, regulations would be put in place, and then the switch would be flipped so that we actually go, let's say from December 31st of one year, anything that happened before then as far as health coverage would be covered by whatever happened before, your private insurance, whatever. And then January 1st, everything else that happens in the state of New York would then be covered by the plan. So that is the first part. Second, I believe that a radical transformation of the system is not only warranted, it is necessary. Going around the edges by going around the edges, which is certainly important to make sure that we can get a better system, ignores the core issue. And the core issue is the insurance industry. That's the core issue. Like, if we do not get rid, because and I understand that this is the way that there's a status quo that has been put into our brains, that the way that we get healthcare is by having insurance. We're kind of built with that. That's the way that's as we grow up, as we start to work, as we talk to our parents about what this is, we're kind of built with this idea that the way to get healthcare is to get insurance. And that is not the way to get healthcare, because again, insurance doesn't guarantee you anything except a card on your pocket. So we have to move away from that and just say, like, matter of fact, what happened over the last couple of years with the pandemic, when we had to figure out how to test everyone, because we knew we had to test everyone. So we created widely available testing sites that were available to everybody. Now, there were certainly issues because we're still in the system that we are right now. But when we moved to get the vaccination, we knew that everybody had to get the vaccination. So we created systems. We're saying, like, if you go in someplace and you're over a certain age, and you, depending on the category, right? Because we expanded the categories. But once the category was there, you went in, you got the vaccination, period. Why? Because we needed it. How about if we treat everything like that? Whether it's dentistry, or whether you have a stomach ache, or whether you have your foot broken, and not just figure out how we're going to make sure that, we get paid for that. The folks, ultimately, we have to get away from this idea that insurance is the way to get care. We have to go towards guaranteeing universal healthcare, period. That's what we're trying to do.
Okay, I have a question that says,
can I respond to that as well?
Oh, absolutely.
So I guess what I would say to that is, certainly number one goal should be universal coverage. Mm-hmm. But there are ways to reduce the cost of insurance that doesn't involve blowing up the system. And I will keep the analogy of blowing up the system. If you look at Vermont, they passed the bill. And it was over the course of those years when they were trying to figure out how to implement it that they decided they couldn't figure it out. It wasn't workable, and they took a step back so it didn't blow up. But you can look at something like what Massachusetts did. You can look at instituting a public option so that there's competition for insurance. I understand that insurance that a for-profit medical system is not the ideal. It's not what we should have. But again, that's a national issue, not a state issue, in my opinion. States can take more conservative, less radical positions, like a public option, looking at something like expanding on what Massachusetts did, to ensure that you have a very good healthcare system that doesn't involve the risks that we are talking about here, and double the size of the state budget while you do it.
Thank you. Okay, I have a question about Medicare and Medicaid. What if I have Medicare and Medicaid? That's all it says. It's like, what if I have Medicare and Medicaid? So I'm not sure what the rest of that question is, but what if I have Medicare and Medicaid?
Then you're dual eligible, but if you have Medicare, I don't understand the question. In this case, if you're a resident of the state of New York, mm-hmm. regardless of how old you are, regardless of your wealth, regardless of your immigration status, you have guaranteed health care, period.
Okay.
We got the way the system.
Okay. Jim Berger?
Yes. I'm sorry I was a little late to this, so I don't know if this has been asked before, but Senator Rivera, I've been working on this for maybe 8 years. We go to Albany every June and lobby. We now have like a big majority in the Assembly that supports this, and a majority in the Senate, even a majority of sponsors in the Senate. What's the roadmap to getting the bill passed?
A very important part is making sure, first of all, we have to get the folks who are not sponsors to become sponsors, but more importantly, we have to get the sponsors who are just sponsors to become champions of it, and to be able to generate a consensus within the conferences. Things get to the floor when the leaders know that they have enough votes to actually pass it, and then there's a consensus that what is going to hit the floor is something that we can all live with. And this is such a difficult and complicated and enormous bill that we're not there yet. So the goal of these conversations is to educate folks on the bill, but certainly as it relates to my colleagues, if they're a sponsor of the bill and they're your senator or assembly member, first of all, thank them. And second, ask them to become a champion of the bill. So we have to have as many people as possible having these types of conversations directly with leadership within the conference to kind of move things in that direction. And these things don't happen automatically, right? We had to know how long did it take for marriage equality to actually be able to be passed? How long did it take for some of the bills that we passed last year around taxation to be passed? How long did it take for the CFE, the Campaign for Fiscal Equity, to actually make it over the finish line? So, and all of that had to do with, certainly there's a lot of outside pressures and we're dealing with those, but then internally to gather and garner enough support so that it becomes an inevitability. So get my colleagues to become champions of it, and push folks to get the leadership to agree that it's something that needs to be dealt with.
Thank you.
Okay, Dan?
Yeah. Hey, thanks again. When I know I'm kind of old, not as old as some folks on this call. I'm not going to call anyone out. But when I was a kid in South Buffalo in the 60s, we had a Dr. Burke used to come make house calls. That's stethoscope around his neck, little black bag. My parents had 9 kids. We'd all line up from teenagers down to infants. He'd bring out the scale. He'd measure us, weigh us, stick the thing in your ear, whatever, hand out medicine if you're sick. And my mom would write him a check. That's the best and cheapest healthcare you can get, is a direct connection between a doctor and a patient. And that's what we're trying to squeeze out here, is those vultures from the insurance firms that come in and they're stealing profit and denying healthcare for people, right? That's what this plan would do. It would get it closer to doctor-patient relationship and get rid of that unnecessary, immoral profit margins. So, God bless you on your mission. Let's get this done. And, again, I hope we can hammer out something I put in the chat across the AFL-CIO statewide that all our affiliates, including CSEA, can buy into. We can move this forward and give the Senate and the Assembly the backbone they need with our support to get this done. Thank you.
And maybe you said this already, Senator Rivera. In the bill as it's written, are there limits on what would be paid to doctors for different services?
So the way that it works is the bill does not have rates that are set, but it does create a board. And part of the responsibility of that board in running the system would be to create a set of rates. But again, as I mentioned earlier, the bill actually has language in it that would make it statutory. So it would be baked into law that the cost of care, as they're setting these rates, that it has to correspond to what the care actually costs to provide. There's nowhere else that such a guarantee exists. And this is a very different thing, because right now, as probably matter of fact, I don't know if there's anybody here from 32BJ, for example, but I know that they're fighting an enormous battle right now because of hospitals determining that the same procedure costing that has about the same amount of positive outcomes, but is charged like all over the place, right? So the rates, it is true that the rates have to correspond so that the people the doctors want to stay here, the hospitals have revenue coming into them. But again, the rates would be set as it relates to what the cost of the care actually is. There's nowhere else where that guarantee exists, and it would be built into statute.
Okay. I don't see any other hands. So I got a question for you. I had a question from my granddad. My granddad is 98, and he's
God bless him.
a veteran of World War II. And his question was, how is this, or, you know, his question was, is this act like the VA? Will it work like the VA works or doesn't work?
Well, remember that the VA is, you have to go care, you have to get care at the VA. Now, it is paid for by, you know, it is a single payer system of sorts when you go to the VA, but there would be some parts of it that would work like that, but the way that it would work is that you would actually go to your local doctor. You wouldn't have to go to a particular provider. You go to your local doctor. You pick a doctor, and so it would work, and you would just get the care that you need.
Okay. And then the other part of that concern was that the doctors don't stay at the VA. So there's a big turnaround. You know, the doctors aren't being compensated well, and they, you know, they cycle in and out because of burnout and the lower pay. So we were just curious if the setup was similar, and if that could happen in this situation.
Remember, the way that the doctors get paid, depending on the type of, you know, they get paid for what they actually do, right? And who they serve, what that person is covered by. Mm-hmm. So if the person, that's the reason why many doctors don't take Medicaid, because they're like, I don't want to get paid that little, so I'm not going to do it. Mm-hmm. There's some people who accept, you know, certain insurances and not another. Sometimes they're excluded from certain networks without their, you know, their consent, et cetera, et cetera. We're going to simplify all that. Again, the rates to be paid to every single person, like there would probably be some regional variations, but the issue is that it depends. The rates to be paid have to do with the cost of care. And by the way, there's also language in the bill that relates to different payment methodologies. It doesn't have to be fee for service. There's different methodologies that exist. For example, something called value-based payment, which is something that we've gone towards, the idea that that people need to, that populations are cared for, that there's particular providers that are responsible for a certain population, and the wellness of that population, as opposed to sick care. We go with well care. So we make sure that people are healthier, so that they have to go to get less services because they're healthier over a long period of time, et cetera. There's different payment methodologies, but the core conceit here is that a statutory standard would exist, that the cost of care and that the cost of the rate has to correspond to what it actually costs to provide the care.
Okay, thank you. We're going to go with Alice, followed by Karen.
Hi, yeah. My question was, I've read through the bill, and I think I remember seeing somewhere in it something about mentioning helping people cover cost of medical education, which, if it's in there, could have a big impact on doctors wanting to be educated and practice in the state of New York.
I don't recall that particular piece. I do know that there's some things that we're doing even in the budget right now. There's a recognition that we have a problem with the healthcare workforce, and there are things that we're discussing in the budget right now to provide better conditions to them. So certainly I don't recall that particular part of the bill, to be honest. Jay Baez, my legislative director, is in here. If he knows it, he should put it in the chat. But I know that it's absolutely something that I want to do everything that I can to make sure that we have more doctors, more practitioners, and that they are not, you know, mired in debt for their entire professional existence.
Thank you for putting that in the room, Alice. Karen?
Hi, my question is actually going back to the Affordable Care Act and the PR nightmare that it was. Are there any plans now to try to start educating not only the doctors in the healthcare industry, but the public at large as the benefits, so that we're not scrambling to get them on board?
This is part of what we're doing in these conversations. You know, and I've done hearings all across the state. My colleague Dick Godfrey has done them as well. I do town halls, and every time that I can, every time that I'm invited somewhere to talk about this, I go. We obviously don't have we're not sitting on millions of dollars like insurance companies that can throw out as many misinformation, bombs as they want. they really they haven't done it yet, but I just expect, I mean, when you see me in black and white on your TV in slow motion with the camera panning closely, it's like, this man wants to take away your children, then you'll know that we'll be winning, because I mean, that'll be ads that'll be thrown against me. But in all seriousness, this is part of what we're doing. We're having these conversations all the time. I would ask you to, and this really quickly, I'd reiterate that you in labor are incredibly essential. Talk to your brothers and sisters, talk to them, engage with them about the questions that they have, bring them back to us. I mean, we said we need to have this back and forth to make sure that we had as much information as possible, and then we make the bill the best that it can possibly be.
Thank you for that. Colin?
Yeah, I just wanted to, this might be a bit of an aside on the information, but I think worth just briefly doing here and thanking, both Chris and Tracy for being here representing the positions of different sides. But knowing that like unions across the state have fallen, a number of unions are on both sides of this question. I'm not going to like throw out a bunch of names right now, but like there are a number of unions very actively putting in memos of opposition to the bill. There are a number of unions straight up funding the campaign to push the bill forward. I think that what I guess all I wanted to highlight was like to thank everyone here for the sort of comradely and friendly discussion, because I actually think that so often in the labor movement, we avoid hard conversations rather than engage in them. And so the degree to which this is like a hospitable sort of discussion and debate environment is really critical to make sure that we can be the democratic movement that we strive to be, right? The small d democratic movement that we strive to be. So I just wanted to take a brief moment to thank everyone for that. Mm-hmm.
Absolutely. Thank you. Thank you, Colin. And I echo that sentiment. Jim?
Yes, Senator Rivera, I want to say, I think you're on the right track with the panel for costs. About 7 years ago, I had my last knee surgery, routine, arthroscopic, outpatient, bare cartilage. Compare prices around the country for the same procedure between 14 grand and 78 grand. There's just no rhyme or reason. It's whatever they can take. Ambulances, prices. You can go to the 2 ambulance websites in this county or anywhere around the country, and I challenge you to find on any of their websites what it costs you for an ambulance ride. You have no idea until you get the bill. So I think that's real commendable. One other point, 7-8 years ago, as head of the local AFL-CIO, on the Blues, I got to appoint 2 labor reps. So naturally, I took them from volunteers who had the most number of union members in their plans. But what I found out on that is at that time, high option family premium was about 15 grand a year. It's about 20 grand a year now. The part of your premium goes in a pot to take care of the uninsured that can't pay. So you're already paying, and I believe it was in the over $1,000. And part of your premium also goes to places like the U of R to subsidize the cost of educating a doctor, even though that doctor or dentist will still come out of med school with anywhere between $150,000 and $250,000. I think it would be a good idea to think about, like we now do with state college, anybody making under a certain amount, the tuition is free. Some of the European countries that have universal health care also pay for the cost to educate doctors and dentists. So they don't have to charge such high fees, because as soon as they start practicing, they owe $250,000. So their education is either paid for or highly subsidized. And as I said, until I appointed members to the Blues, I went to a Blues meeting, I didn't know that part of my healthcare premium was going to pay for the uninsured and to pay the cost of educating doctors. That's part of what you're already paying in your healthcare premium.
Okay. I'm seeing no other hands. this would be the part where we do the concluding remarks, and I'm still waiting. I see no other hands. All right. Then it appears that we have no further questions today. So I would like to thank you so much for participating in the Labor Lyceum today. A huge hand clap goes to our panelists, New York State Senator Gustavo Rivera, SEIU Vice President Tracy Harrison, and a Political Action Coordinator, Chris Rocco, for sharing your time and expertise with us today. You absolutely gave us a lot to think about. I'd like to say thank you to the Education Committee who organized this event: John Garlock, Ellen Mancuso, Vincent Cervallo, Colin O'Malley, Jeff Nizansky, Donald Marthage, Linda Donahue, and Sharifa Pryor. If you are interested in joining our committee and being part of a team that makes conversations like these possible, please send an email to Colin or to me. I just put our emails in the chat. And we'd love to have you join our team. And finally, we'd like to just extend a very special thank you to you for your time and for your participation in this conversation. It's absolutely been the greatest pleasure to learn with you today. So get out there and enjoy that snowy Saturday. And we hope that we have.
I think Senator Liu has their hand up.
Senator John Liu kind of came in at the end and raised his hand.
Senator John Liu, I've already said goodbye.
I'm just gonna say goodbye. I didn't come in at the end, G. I was in from the beginning.
So there.
Sorry, buddy.
I just wanted to say thanks to Senator Rivera for corralling our colleagues, not only for this particular meeting, but this guy is relentless. I do want to affirm, though, that he is actually not trying to take our kids away. He doesn't want kids.
No, you can keep your kids. I don't want your kids. Keep your kids. Keep your kids.
See, now that is something that as a former teacher and as a current rep for teachers and other educational professionals, we're glad you finally understand exactly how much work it is that we do with your kids. Be like, the last 2 years taught a lot of folks some things that they didn't know about their babies. So, and because it's important for me to have the last word, I'd just like to say again to you, thank you so much. It's been a true pleasure to learn with you. And we look forward to seeing you at our next conversation, our next Labor Lyceum. Be well.